Morning class. So today we're going to be going over chapter 25, bleeding. Trauma applies fundamental knowledge to provide basic emergency care and transportation based on assessment findings for an acutely injured patient. Bleeding recognition and management of bleeding, pathophysiology, assessment and management of bleeding. Pathophysiology applies fundamental knowledge of the pathophysiology of respiration and perfusion to patient assessment and management. Introduction. Important to be able to recognize bleeding, understand how bleeding affects the body. Bleeding can be external or internal. Bleeding can cause weakness, shock, and death. Anatomy and physiology of the cardiovascular system. The cardiovascular system circulates blood to cells and tissues, delivers oxygen and nutrients, carries away metabolic waste products, responsible for supplying and maintaining adequate blood flow. So 3 parts are going to be your pump, your heart, container, blood vessels. Excuse me. Fluid, blood, and body fluids. And picture how your heart works and how the blood pumps through the heart, as well as to your lungs and back into your body. So the heart needs a rich and well-distributed blood supply. It works as 2 paired pumps. Upper chamber is going to be your atrium. You're going to have 2 of those, and as well as your lower chamber, you're going to have 2 ventricles. Blood leaves each chamber through a one-way valve. So remember, I drew that great picture of how the heart works. You're going to have your superior vena cava up here, your inferior vena cava down here. Blood's going to come to the right atrium and go down to the left ventricle, going to pump blood to the lungs to get oxygenated, and it's going to pump back into the left atrium, and then go back down to the left ventricle, and pump out oxygenated blood to the rest of the body. And you're also going to have valves in between your atriums and your ventricles to prevent blood flow from going backwards. So arteries carry blood away from the heart. Arterioles, smaller vessels that connect the arteries and capillaries. Capillaries pass among all the cells and link arterioles and venules. So venules, very small, thin-walled vessels that empty into the veins. Veins carry blood from the tissues to the heart. So oxygen and nutrients pass from the capillaries into the cells, and waste and carbon dioxide diffuse into the capillaries. So blood contains red blood cells, responsible for the transportation of oxygen to the cells and carbon dioxide away from the cells to the lungs. So white blood cells, responsible for fighting infection. Platelets, responsible for forming blood clots. What do we use? What medication do we use for chest pain? It's going to be aspirin. It's antiplatelet. It's going to prevent that clot from getting bigger if there is a clot. And plasma as well in your blood. So blood clot formation depends on blood stasis, changes in the blood vessel walls, blood's ability to clot. When tissues are injured, platelets begin to collect at the site of injury. Red blood cells to become sticky and clumped together. Autonomic nervous system monitors the body's needs, adjusts blood flow, automatically redirects blood away from other organs to the heart. Brain, lungs, and kidneys in an emergency, adapts to maintain homeostasis and perfusion. So pathophysiology and perfusion. Perfusion is the circulation of blood within an organ or tissue to meet the cell's needs for oxygen, nutrients, and waste removal. So speed of blood flow, fast enough to maintain circulation, slow enough to allow cells to exchange oxygen and nutrients for carbon dioxide and waste. Some tissues need a constant supply of blood, while others can survive with very little. All organs and organ systems depend on adequate perfusion to function properly. Death of an organ system can quickly lead to the death of a patient. Emergency care supports adequate perfusion until the patient arrives at the hospital. So ABCs, very important. So the heart requires a constant supply of blood. Brain and spinal cord may last 4 to 6 minutes. Lungs can only survive about 15 to 20 minutes. Kidneys may survive 45 minutes. Skeletal muscles may last 2 hours. Times are based on a normal body temperature. So this is why it's important as soon as you get on scene to maintain the airway, make sure they're breathing, or we can breathe for them and try and get them some oxygen. So external bleeding. Hemorrhage means bleeding. That's going to be your medical term. External bleeding is a visible hemorrhage. Includes nosebleeds and bleeding from open wounds. So significance of external bleeding. With serious external bleeding, it may be difficult to tell the amount of blood loss. Blood looks different on different surfaces. Estimate the amount of external blood loss. Body will not tolerate a blood loss greater than 20% of blood volume or more than 1/5. Changes in vital signs may occur with significant blood loss. Increase in heart rate, increase in respiratory rate, and decrease in blood pressure. So those are going to be your main signs of shock as well to look for a patient. So how well people compensate for blood loss is related to how rapidly they bleed. An adult can comfortably donate 1 unit of blood over 15 to 20 minutes. Similar blood loss occurs in much shorter time. The person may rapidly develop symptoms of hypovolemic shock. Consider age and pre-existing health. So your characteristics of external bleeding. Serious conditions with bleeding, significant MOI or mechanism of injury. The patient has a poor general appearance and is calm. Signs and symptoms of shock, significant blood loss, rapid blood loss, uncontrollable bleeding. Arterial bleeding, pressure causes blood to spurt and makes bleeding difficult to control. Typically bright or red and spurts in time with the pulse. Venous bleeding, dark red, flows slowly or rapidly depending on the size of the vein. Does not spurt and is easier to manage. So for arterial bleeding, we're most likely going to get a tourniquet and direct pressure, try and control that bleeding, because anybody who has an arterial bleed is going to bleed out pretty quickly. So capillary bleeding, bleeding from damaged capillary vessels, dark red, oozes slowly, steady but slowly. So here's your different types. You got your capillary down here, and that's probably going to be close to an artery right there. So you see all that blood coming out. So clotting. Bleeding tends to stop rather quickly within about 10 minutes. When skin is broken, blood flows rapidly. The cut end of the vessel begins to narrow, reducing the amount of bleeding. Then a clot forms. Bleeding will not stop if a clot does not form. So despite the efficiency of the system may fall in certain situations, movement, disease, medications, removable bandages, external environment, body temperature, and severe injury. So hemophilia, patient lacks blood clotting factors. Bleeding may occur spontaneously. All injuries, no matter how trivial, are potentially serious. Patients should be transported immediately. So have a high index of suspicion for these people who have medical condition of hemophilia. These people tend to bleed a lot easier. Small injuries to them may cause extreme bleeding. So always be aware and always try and transport these people if possible. So internal bleeding. Bleeding in a cavity or space inside the body can be very serious because it is not easy to detect immediately. Injury or damage to internal organs commonly results in extensive internal bleeding. Can cause hypovolemic shock. Possible conditions causing internal bleeding: stomach ulcer, lacerated liver, ruptured spleen, broken bones, especially in the ribs or femur, pelvic fracture. So MI for internal bleeding, high energy MOI should increase your index of suspicion for serious unseen injuries. This is why we do a physical assessment. That's why I keep telling you guys have to do a physical assessment. You have to check underneath their clothes, cut their clothes off, see if there's any bruising. Internal bleeding is possible whenever the MOI suggests that severe forces affected the body, blunt trauma, penetrating trauma. So anything, any kind of car accidents, any other types of mechanisms with high trauma, you're going to check underneath the patient's skin. This is why we cut the patient's clothes off as well. We want to make sure there's no internal bleeding that we can't see. So signs of injuries, a decap BTLS. You guys should all know this by now. Deformities, contusions, abrasions, punctures, penetrations, burns, tenderness, lacerations, and swelling. So internal bleeding is not always caused by trauma. Non-traumatic causes include bleeding ulcers, bleeding from colon, ruptured ectopic pregnancy, and aneurysms. So frequent signs: abdominal tenderness, guarding, rigidity, pain, and distension. In older patients, signs include dizziness, faintness, weakness. Ulcers or other GI problems may cause vomiting of blood, bloody diarrhea, or urine. So anytime patient has any genitourinary problems, either with their urine or stools, you always want to ask them what color it is. And that could probably tell you if they have a GI problem or a kidney problem. So always ask what color it is. Signs and symptoms of internal bleeding. Pain most common, swelling in the area of bleeding, distension, dyspnea, tachycardia, hypotension, hematoma, bruising. So bleeding from any body opening, hematemesis, which means coughing up blood, melena, or blood in the stool, pain, tenderness, bruising, guarding, or swelling, broken ribs, bruises over the lower part of the chest, or a rigid distended abdomen. So hyperperfusion, change in mental status, weakness, faintness, or dizziness on standing, changes in skin color or pallor, pale skin, later signs of hypoperfusion, tachycardia, weakness, fainting, or dizziness at rest, thirst, nausea, and vomiting, cold, moist, clammy skin. Later signs of hypoperfusion, shallow, rapid breathing, dull eyes, slightly dilated pupils, capillary refill of more than 2 seconds in infants and children. And so that's going to be a delayed response. So what is it an adults should have? It's going to be less than 4. For adult females, it's going to be less than 3. So weak, rapid, thready pulse, decreasing blood pressure, altered level of consciousness or ALOC. Scene size up, scene safety, be alert to potential hazards. Always protect yourself and your partner first. At vehicle crashes, ensure the absence of leaking fuel and energized electrical lines. In violent incidents, make sure the police are on scene. Follow standard precautions. Mechanism, injury, nature of illness, determine the NOI or MOI. Consider the need for spinal mobilization and additional resources. Consider environmental factors such as weather. Primary assessment, do not be distracted by identifying life threats. Form a general impression. Note important indicators of the patient's condition. Be aware of obvious signs of injury. Determine gender and age. So you're always looking for clues, signs and symptoms when you're walking on scene. What are you walking into? What kind of safety issues are presented? What must the patient be suffering from? How does the patient look? Is the patient tracking you? Is the patient responsive? Is there any life threats? Any external bleeding? Any arterial bleeding that you guys have to be aware of? So perform a rapid exam. Look for life threats and treat them as you find them. If the patient has obvious life-threatening external bleeding, address it first. Assess skin color. Does a patient look pale, cool, diaphoretic? It's probably going to be a good indication that they have some type of bleeding somewhere because all their blood is shunting to their vital organs. All their blood's going to their core, so they're not going to have much blood on their peripheral extremities. Determine level of consciousness. Airway and breathing. Consider the need for spinal stabilization. Ensure a patent airway. Look for adequate breathing. Check for breath sounds. Provide high flow oxygen or assist ventilations with a bag valve mask or non-rebreather. Insert an OPA if the patient is unconscious. Circulation. Assess pulse rate and quality. Determine skin condition and color and temperature. Check capillary refill time. Control external bleeding. Treat for shock. Transport decision. Assessment of ABCs and life threats will determine the transport priority. Signs that imply rapid transport, tachycardia or tachypnea, low blood pressure, weak pulse, clammy skin. So investigate the chief complaint. Look for signs and symptoms of other injuries due to the MOI and or NOI. Note obvious signs of internal bleeding. Assess the entire patient. If a patient has a big trauma, We want to assess the whole body, even though the patient may only be complaining of one thing or might have a distracting injury, as we call it, maybe a compound fracture or a broken arm. It doesn't mean that's going to be their only medical problem. You always want to do a full assessment if you guys can. Make sure you guys aren't missing anything. So sample history, ask the patient about blood thinning medications, especially for older people who have falls and hit their head. They could have a serious head bleed. For our county, for most counties, that's going to fall into a trauma. Patients older than 65 who are on blood thinners and hit their head, that's going to be probably a trauma activation. If the patient is unresponsive, obtain history from medical alert tags or bystanders. Look for signs and symptoms of shock. Determine the amount of blood loss. Secondary assessment. Record vital signs. Complete a focused assessment of pain. Attach appropriate monitoring devices. With the critically injured patient or a short transport time, there may not be time to conduct a secondary assessment. Make sure your ABCs are good. Make sure the patient has an airway. Make sure they're breathing. Make sure they're having good circulation. You may not have time to get to everything. If the patient needs to go to the hospital, it's going to be a load and go. Make sure their ABCs are good. So assess all anatomic regions for decap BTLS. Look for uncontrolled bleeding from large scalp lacerations. Feel all four quadrants of the abdomen or tenderness, or rigidity. Record pulse, motor, and sensory function in extremities. So make sure you're checking CSM in all extremities and make sure they're equal to each other. That might tell you something else is going on. They're not equal. So vital signs. Assess vital signs to observe the changes that may occur during treatment. A systolic blood pressure of less than 100 millimeters with a weak rapid pulse should suggest the presence of hypoperfusion. So the patient probably has a bleed somewhere, either external or internal. Cool, moist skin that is pale or gray is an important sign. Repeat the patient in areas that showed abnormal findings. Signs and symptoms of internal bleeding are often slow to present. Reassess an unstable patient every 5 minutes and a stable patient every 15 minutes. So interventions: provide high flow oxygen, control external bleeding, provide treatment for shock and transport rapidly. Do not delay transport of a patient to complete an assessment. Like I said, you might not have time to complete a full assessment, and it happens sometimes. It's more important that the patient gets to the hospital and gets the appropriate medical care and gets seen by a doctor. Sometimes there's things you can't fix on scene or you can't fix en route, and that's okay. But you need to make sure if the patient has serious injuries, patient needs to get to a hospital. Patient doesn't need to be have a full assessment conducted on them sometimes. You just need to get to the hospital. Communication documentation: recognize, estimate, and report the amount of blood loss and how rapidly or over what period of time it occurred. Communicate all relevant information to the staff of the receiving hospital. Document all injuries, care provided, and patient's response. So when you call in your report to the hospital, make sure you tell them the mechanism. Make sure you tell them what you're seeing. Make sure you tell them all the injuries that you find. Like I said, sometimes you're not going to have time to check the patient out and do a full assessment. Sometimes you're going to miss injuries, and it happens sometimes. You just don't have enough time, enough hands to fully assess the patient, and that's okay. But make sure that you get the patient to the correct hospital and in a fast manner. So emergency medical care for external bleeding: follow standard precautions, wear gloves, eye protection, possibly a mask or gown. Make sure the patient has an open airway and is breathing adequately. Provide high flow oxygen. Control obvious life-threatening bleeding as quickly as possible. Several methods are available to control external bleeding: direct, even pressure, and elevation. So first thing you're going to do is put pressure on the bleed. You're going to elevate it above the heart. Pressure dressing or splints, and then your last resort's going to be tourniquets. If you have an arterial bleed, you're probably going to just go ahead straight to direct pressure and try and apply that tourniquet as soon as possible. So direct pressure, most effective way to control external bleeding. Pressure stops the flow of blood and permits normal coagulation to occur. Apply pressure with your gloved fingertip or hand over the top of a sterile dressing. Hold uninterrupted pressure for at least 5 minutes. Pressure dressing, firmly wrap a sterile, self-adhering roller bandage around the entire wound. Use 4x4 sterile gauze pads for small wounds and sterile universal dressings for larger wounds. Cover the entire dressing above and below the wound. Stretch the bandage tight enough to control the bleeding. You should still be able to palpate a distal pulse. Do not remove a dressing until a physician has evaluated the patient. This is important. Once you wrap a patient, it's like when you C-spine somebody. Once you C-spine a patient, they're C-spine until they get to the hospital. You don't take off the C-collar. You don't take them off the backboard. You wait till the doctor checks them out. You wait till you get to the hospital. And once you bandage a wound, once you look at it and you assess it and you wrap it up, that's it. You guys don't go back and look at it. Bleeding will almost always stop when the pressure of the dressing exceeds arterial pressure. Hemostatic agents. Any chemical compound that slows or stops bleeding by assisting with clot formation can be used with direct pressure when direct pressure alone is ineffective. The use of hemostatic agents in EMS remains largely experimental. Be aware of and follow local protocols. So tourniquet. Useful if a patient has substantial bleeding from an extremity injury. Several types of commercial tourniquets are available. If a commercial tourniquet is unavailable, you can create a tourniquet using a triangular bandage and a sticker rod. So basically, you grab a triangle bandage, you wrap it around the wound or the laceration. You grab a pen or a stick, and basically just go in a circle, and it'll go ahead and tighten. Make sure you tie the sticker rod to the ends of the tourniquet bandage, and just twist in a circular motion. It'll eventually get tighter and tighter on that. Another thing you could use too is your belt. Most people wear a belt, especially if you're out in the field or if you're out in the park one day and something happens. You can take off your belt and use that as a tourniquet until EMS or 911 arrives. So you basically use anything for a tourniquet. So observe the following precautions. Do not apply a tourniquet directly over any joint. Always place the tourniquet proximal to the injury. Make sure the tourniquet is tightened securely. Never use wire, rope, a belt, or any other narrow material. I know I said that you could use your belt, but if you have nothing else and you're off duty, a belt's going to work great. A belt, it may not work, but that's the best you got. So you go ahead and try that. So tourniquet, observe the following precautions. Place padding under the tourniquet. Never cover a tourniquet with a bandage. Do not loosen the tourniquet after you have applied it. So another thing, you're not taking a tourniquet off either. Wait till they get to the hospital. Wait till a doctor checks them out before you take off the tourniquet. Usually the doctor will take it off, or one of the nurses. So splints, air splints, soft splints or pressure splints can control internal or external bleeding associated with severe injuries. So this looks like an air splint. So for a broken arm, you wrap it around, and you're going to have a little pump. Looks like pump might be right there. And it's going to blow up, and it's going to keep the patient's arm stabilized. Depends on which county you work in. Depends on which fire department carries these. I haven't seen these in a while. So air splints mobilize fractures, act like a pressure dressing. Use only approved, clean, or disposable valve stems. So rigid splints will help immobilize fractures, reduce pain, prevent further damage to soft tissue injuries. And once a splint is applied, monitor circulation in the distal extremities. So bleeding from the nose, ears, and mouth, several conditions, skull fracture, facial injuries, sinusitis, infections, use and abuse of nose drops, dried or cracked nasal mucosa, high blood pressure, coagulation disorders, digital trauma. Epistaxis, nosebleeding is a common emergency. Occasionally, it can cause enough blood loss to send a patient into shock. Can usually be controlled by pinching the nostrils together. So, if you have a nosebleed, sit forward and pinch your nose. Do not put your head back. This is going to cause the bleeding to either go back into your head or back down to your stomach. It's going to get caught up in your airway and you're going to start coughing up blood, or go down to your stomach. Blood is a gastric irritant. It's going to actually cause you to throw up, and then you're going to have a second problem. So anytime you see somebody with a nosebleed, have them sit forward, lean forward, and pinch the top of their nose on the tissue part. So bleeding from the nose or ears following a head injury may indicate a skull fracture. May be difficult to control. Do not attempt to stop blood flow. Loosely cover the bleeding site with a sterile gauze pad. Apply light compression with a dressing. A target or halo-shaped stain may occur on the dressing if blood or drainage contains cerebral spinal fluid. So here's a picture of it, and you see the blood right here, and I'm not sure if you guys are able to really tell, but right on the outside right there, it's going to be your kind of yellow or pus-stained fluid or cerebral spinal fluid. So emergency medical care for internal bleeding usually requires surgery or other hospital procedures. Keep the patient calm, reassured, and as still and quiet as possible. Provide high flow oxygen. Maintain body temperature. Splint the injured extremity or air splint. So review. Which of the following is not a component of the cardiovascular system? So B, components of the cardiovascular system includes the heart, blood vessels, arterioles, capillaries, venules, and veins, and blood, plasma, and blood cells. The lungs are a component of the respiratory system. It's not part of the cardiovascular system, but blood flows through it. So perfusion is most accurately defined as So C, perfusion is the circulation of blood within an organ and tissues with sufficient amounts of oxygen and other nutrients. Carbon dioxide is a byproduct of normal cellular metabolism. It should return to the lungs for removal from the body. It should not accumulate at the cellular level. So a man is involved in a motorcycle crash and has multiple abrasions and lacerations. Which of the following injuries has the highest treatment priority? What are your three main types of bleeding? You have capillary, you have venous, and you have arterial bleeding. What is going to kill you first? It's most likely going to be arterial bleeding. So D, bleeding from an artery produces bright red bleeding that spurts with the pulse. The pressure that causes the blood to spurt also makes this type of bleeding difficult to control. Blood loss from an arterial wound is more severe and thus more life-threatening than a venous wound. So which of the following sets of vital signs is least indicative of internal bleeding? So what are your signs and symptoms of shock? What does the body do to help compensate? So A, internal hemorrhage typically reveals vital signs that are consistent with shock, hypotension, tachycardia, and tachypnea. Hypertension, bradycardia, and bradyapnea. Choice A is consistent with a closed head injury, not internal bleeding. So when caring for a patient with internal bleeding, the EMT must first what is the first thing you're going to do for any patient, for any and every patient? Remember, what is the question asking for? All the interventions in this question must be performed, however, before providing patient care. Whether the patient is bleeding or not, the EMT must first ensure that he or she has taken the appropriate standard precautions. So remember, you guys have to memorize your medical and your trauma assessments. Always know what comes first before you start. So take appropriate standard precautions. The very first thing, PPE on every call. The quickest and most effective way to control external bleeding from an extremity is, what's the very first thing you're going to do anytime you see bleeding? So B, direct pressure is the quickest, most effective way to control external bleeding from an extremity. This will effectively control external bleeding in most cases. So remember, direct pressure and elevation, first thing you're going to do for any type of bleeding. When applying a tourniquet to an amputated arm, the EMT should So remember, what are the indications and contraindications for using a tourniquet? What should you use and what should you not use? So B, if you must apply a tourniquet, never apply it directly over a joint. You should use the widest bandage possible and make sure it is secured tightly. Never use wire, rope, a belt, or any other narrow material as it could cut the skin. The tourniquet should never be covered with the bandage. Leave it in open and full view. This way you could see if the tourniquet's working or not, if the patient's still losing blood. You may have to put a second tourniquet on. Do not take off the first tourniquet and readjust it. Just use a second tourniquet. So remember, you're not going to use the most narrow bandage possible. You want to use it the widest. You're not going to apply a tourniquet over a joint. You're not going to cover a tourniquet with a sterile bandage. And you're never going to use wire, rope, belt, or any other narrow material as it may cut or damage the extremity. So a 70-year-old man has experienced a severe nosebleed. When you arrive, you find him leaning over a basin which contains an impressive amount of blood. He has a history of coronary artery disease, diabetes, and migraine headaches. His BP is 180 over 100 and his heart rate is 100 beats a minute. Which of the following is most likely contributing factor to his nosebleed? Remember, what are the common causes? Early in the presentation that talked about why a patient might have a severe nosebleed. So A, several conditions can cause a nosebleed: epistaxis, including skull fractures, facial injuries, sinusitis, inflamed sinuses, high blood pressure, and coagulation disorders, i.e. hemophilia, and digital trauma, i.e. nose picking. A BP of 180 over 100 indicates a significant amount of pressure on the arteries, which is no doubt the main contributing factor to this patient's nosebleed. So when caring for a patient with severe epistaxis, the most effective way to prevent aspiration of blood is to remember what I said, how to control a nosebleed. What are the things you want to do? What are the things you don't want to do? So B, leaning forward with the head tilted forward will stop bleeding from trickling down the throat. This decreases the risk that patient will swallow blood, which may cause vomiting or aspirating the blood into the lungs. And you're going to have a second problem and possibly a third problem. So controlling internal bleeding requires what? So B, controlling internal bleeding usually requires surgery that must be done in the hospital. To care for the patient in the field, administer high flow oxygen and assist ventilation if needed. Control all obvious external bleeding. Monitor and record the vital signs every 5 minutes. Place a non-trauma patient in a shock position. Keep the patient warm and provide immediate transport. So you're not going to apply a tourniquet because it's going to be internal bleeding. Tourniquet's not going to help. You're going to place patient in a supine position, not a sitting position. And you should provide immediate transport, not slow and considerate transport. Patient needs to see a doctor. There's not much you're going to be able to do for him. Patient needs surgery.